Lily, and welcome everyone. It's a pleasure for me this afternoon to introduce Dr. Teresa LaFromboise. Dr. LaFromboise is a psychologist and a professor in Developmental and Psychological Sciences at Stanford University. And her research focuses on efforts of minoritized groups to thrive despite adversity, including discrimination, acculturation, demands, and major life challenges. And I'll say that 25 years ago, when I was working on my dissertation, her work in this area was an influence on me. And so it's a special thrill for me to be able to introduce her today. She has extensive experience in developing and evaluating community-based psychological interventions with American Indian and Alaska Native adolescents, as exemplified in her development of the American Indian Life Skills Development Curriculum, which is widely used in Native communities throughout the country. In addition, she serves as the director of the Native American Studies program at Stanford, contributes to the Child Health Research Institute at the Stanford School of Medicine, and the Centers for American Indian and Alaska Native Health at the University of Colorado School of Public Health. Dr. LaFromboise is a fellow in the American Psychological Association and the Association for Psychological Science. She's past president of Division 45 of APA and past president of the Society of Indian Psychologists. She's currently conducting a community-initiated study of belongingness, racial identity, bicultural competence, psychological well-being, and academic engagement for a tribal college in the upper Midwest. She's currently here with us in New Mexico on a Scholar in Service Fellowship from Stanford. And she's working with the RMP Foundation to better understand how mental health professionals use cultural connectivity in interventions to prevent suicidal behavior. So it really is truly just an honor and a pleasure for me to introduce Dr. LaFromboise today. Teresa?
Okay, thank you so much. And Chris, I'm going to have you help me with the slides. For some reason, I'm not good at that, or at least not out here. Is that okay? Can you put those up?
Sorry, I had already muted myself. Yes, indeed. I will get those up right now and get my screen shared.
Great, thank you very much. Okay, so first of all, I want to tell everyone that's here today. My goodness, 45 people. That's wonderful. That I'm very thankful to be able to share this work, to be invited to, participate with you here in, sharing this, and also maybe hopefully with the Q&A a little bit of some, thought experiments around how to improve and expand it if at all possible. And I love New Mexico. I wish I could stay. I'm going to be here until the 1st of March because it's lovely place and wonderful people. So how are we doing?
Very close now.
So what I thought I would do today is share with you a presentation that I did just a little while ago at the Center for Disease Control and Prevention on different that was centered around different contexts for suicide prevention, along with Dr. Spiro Manson and Mike Flynn. Spiro talked a lot about medical settings, and Mike Flynn talked about work settings, and I chose to talk about school settings because I think that we often overlook those. So I'll share with that, and then we'll go on from there. So could we have the next slide, Chris? So in order to sort of set the stage, I'm sure I'm not showing you anything that you don't already know, but would like you to see this chart on leading causes of death by race and ethnicity. And the middle column there is the non-Hispanic American Indian Alaska Native column. And you can see that that suicide is the 8th leading cause of death for this population. Next slide. Okay. This particular slide is looking at younger ages and the rates of suicide over time. by age. And what you see here is really what is unique about, and of course, when we're thinking about doing and developing culturally grounded interventions, or even culturally tailored interventions, one of the rationales for doing that is that there's something unique about it. It's different than what's already on the shelf and in our libraries about, and treatment manuals about suicide prevention. And clearly, the sort of mustard colored line is the American Indian, non-Hispanic American Indian Alaska Native line, and you can see that the 15 to 25 year age range is at extremely high risk for suicide. That is what is different than the non-Hispanic white population, which is sort of the purple line, and then the other populations in terms of non-Hispanic Asian, Hispanic, and non-Hispanic Black. Did we lose our sequence or something? I'm not sure.
Now I'm messing this up.
Okay, so we're going to the third slide there. And sometimes people ask, well, why do we think that there are these disparities for the 15 to 25 year age range? And this is speculation at this point. But we're really talking about high rates of adverse childhood events, high rates of violence and trauma included in that, early onset of substance use, high rates of psychological disorders, historical threats to the extended family functioning due to out-of-home placements, large number of out-of-home placements, and of course the history of boarding schools, and then pervasive poverty. And I guess we could say, aside from that, at this moment, the disproportionate brunt of COVID in a lot of Native communities, and maybe the current state of direct services in mental health care, given the pandemic as well. So the slide that's the predominant slide at this point is suicides, is really about the cost, the burden of suicidal behavior. And, as you know, it's, a low case rate in terms of the actual deaths by suicide. But for, every death by suicide, there are twice as many hospitalizations, 13 as many suicide attempts, and about 80 times as many people who have seriously considered suicide. So people like me who are counseling psychologists, we kind of concentrate on the lower end of that iceberg or pyramid, however you want to look at it. But I know those who are in psychiatry are really concerned about people that are hospitalized and who have made attempts. But in all, it's very costly to people, and communities, the loss of young lives, the desperation that comes with losing young people, and the sense of the hope of future for the community, the way it disrupts families and communities. And then the related, economic costs of hospitalization and inpatient treatment or ongoing therapy. So suicide is very costly for Native people. And this is the data with Native Americans. Next slide, please. All right. This is looking about how suicide has increased over time. And it's still increasing, I think. Last year, they reported that there hadn't been an increase, the CDC, but it was also stated with the caveat that they felt that probably record keeping was at risk at this time, given the pandemic. So, but I think we all, those of us in mental health, see that there's a lot of suicidal behavior and probably increased rates, again. But something happened in around 2014, as you can see, that the rate, among persons that are 10 years of age or older has risen steadily, and it really is going up steeply from about 2014 to the present, especially with American Indian Alaska Natives and non-Hispanic whites, and and it's very serious. I think also, I know I concentrate on suicide prevention because of the nature of this intervention, But those of us that are in mental health fields and psychiatry, we do know that there are elevated rates of substance use disorders, conduct and oppositional defiant disorders, attention deficit disorders, and post-traumatic stress disorders as well. So that's the end of the negativity around defining the problem. And I also have to say that I always feel awkward in giving these slides. I know we sort of have a tradition of talking about stating the extent of the problem before we get going on interventions, because I don't want to pathologize. I think that there's an incredible amount of resilience in Native communities that we as a field are not good enough yet in capturing in research. So if we could go on to the next slide, it's sort of the word splash, Chris. Okay, thank you. All right. So I want to mention schools as a context for suicide prevention. And I think it's really relevant to those of you probably that are on this webinar, because if you're in psychiatry, you are the ones that people consult. You are the ones that, in terms of school-based mental health, they will probably listen to the most. And I'm really here to try to persuade you to advocate for school-based suicide prevention. As you know, schools are second to families in their potential to affect children's mental health because of the amount of time that children spend in schools. And I think it's safe to say that schools are the de facto mental health centers for many children. And unfortunately, the American Foundation for Suicide Prevention only identifies healthcare systems, emergency departments, correctional systems, and firearms as critical contexts for suicide prevention. They don't ever mention schools, and I'm trying to change that around. Okay, and the reason is that a few years ago when we did a study in the Northern Plains on suicidal ideation, suicide attempts, we found that 25% of the students, and this is high school students, had attempted. At least they self-disclosed that they had attempted. And we even had an open-ended question. Well, if you have attempted, would you please explain, share with us what was going on with you at the time? In other words, why did you do this? And I was amazed at how many of them filled it out. And they even sometimes elaborated in the margins more information about, kind of what led them to that. And then we asked, did you see anyone? Who did you see afterwards, after you had attempted? And we listed a number of people. And of course, we listed IHS behavioral health in the emergency rooms. And basically we found that 95% of the children in our study that had attempted didn't go to anyone for help. They didn't go to the hospital for help. Let's just say that they did not go. And therefore, what I'm trying to say is that if we can work with educators who I believe are, and if they were trained in suicide prevention and they were sensitive, they could be, and also other school personnel, they could be the people that youth consider talking to if they're upset and thinking about suicide. And they could then get them to a trusted adult or to psychological services and provide that. Now, this is not a new concept. It's been in existence since 1984, when prevention programs started to occur in schools because of an escalating rate of suicide in Western industrialized nations. And it's based on the idea and the rationale that for suicide prevention programs in schools, that a significant amount of suicidal behavior occurs among ostensibly well-functioning students. So if teachers could be sensitive to shifts in moods and behaviors, we might be able to, on the front line, be able to get better referrals to psychological services. Next slide, please. So I'm sharing with you like something that I have an incredible amount of gratitude for, and that is being invited by the Pueblo of Zuni to design a suicide prevention program. And the way that this happened actually is that at the time, there was a committee formed by leaders in the Zuni Pueblo and some staff and faculty at Stanford, and it was called the Zuni Stanford Committee. It was made up of faculty that were invited into this committee based on what Zuni wanted in terms of consultation. So we had people from the provost's office in terms of leadership skills with the tribal council. We had people from the business school that worked with the co-ops in terms of the jewelry industry. We had someone from linguistics that worked with the Zuni radio station. And I was invited to the committee because the superintendent of the committee really, at the time, whose name was Hayes Lewis, was a very good friend of a woman named Ann Medicine, who was at Stanford, and they had been in school together at Harvard, and they were the ones that formed the committee. And in the process of this, Mr. Lewis asked me if I knew anything about suicide prevention. And at the time I had, in my first year of doctoral work, I had volunteered on a suicide crisis line. And I had just recently had an article published that I co-authored with Dolores Bigfoot on cultural and cognitive considerations of Native American adolescent suicide. That was the extent of experience I had. But I said, I'd be, interested in helping out if you thought that there was something I could do. So over a 3-year period of time, I worked with my students and community members in the Pueblo of Zuni to develop, evaluate, and implement the it was called the Zuni Life Skills Curriculum. So this is a culturally grounded, bottom-up, universal suicide prevention curriculum that was developed at Zuni High School. Okay, next slide, please. Is it moving? It's a nice time to kind of pause.
I don't know what the problem is, I must be honest.
That's okay.
I will keep at it.
I'll keep talking then. Hi, Maria.
I was gonna say that Buffalo Spirit doesn't want to move.
No.
That's what I see.
That's good.
And those are the colors, and they're different with different tribes, even within the same tribe. But so those colors, not necessarily in that order, but are that's what the Sitting Bull Sundance. So
Thank you.
it's interesting.
I got it. Sorry about that. My apologies.
No, that's okay. Thank you. Thank you, Maria. That helped. Okay. So what I have here is a chart that was from a committee that I worked with the National Academy of Sciences on prevention of mental, behavioral, and emotional disorders of youth. And it's envisioning in a just society what would be available in terms of prevention for everyone. And I'm trying to, I have outlined this sort of box here is, in a way where something like suicide prevention would go. Certainly this is very much a skills training intervention. It fits within this area around social and behavioral skills training. It is classroom based. Instead of preventing substance abuse or aggressive behavior or risky sex, we're trying to prevent suicide. And you can also see the prevention of depression. But the point is that we were asked to do it in the Zuni High School because they had had 5 deaths by suicide the year that they decided that they were going to get some outside consultation to try to handle the situation. They didn't want to, and I understand that. But when I was asked, knowing prevention, I really wanted to do it in the middle school. And I, about 3 trips out, kept asking, could we do this in the middle school rather than the high school? And then I was sort of sternly told, you've been invited to do it in the high school. And so that's what we did. But what this graph is showing is the importance of prevention at all stages. And the hope is that we would start as early as possible. And the thing that's so sad now, knowing that we have children as young as 8 years old attempting suicide, or at least really actively talking about it, that would be very young to be able to do that. All right, so I just want to mention that. Another is that this is to talk about the theories related to this. As you can see, just at the very bottom of this slide, I mentioned that social cognitive theory is really the major theory that undergirds social Zuni life skills. And I think the reason for that is, well, one, that I studied at Stanford, and I didn't get my degree there, but I was working there, and of course I did study social cognitive theory in my training. Which what I always appreciated about that was that it emphasized the behavior of a person, their emotions, and the environment, and that reciprocal interaction among those three facets. And so, but the important, it did, this is before Bronfenbrenner's work got to be so popular, but basically it always, Bender, it did emphasize, situational determinism and the environment. And so I felt that was very important here. Another theoretical orientation is cognitive behavioral theory. And the reason for that, I think, is that it, with cognitive behavioral theory, you're talking about thoughts, beliefs, and values. And to me, that is a nice foundation to be able to think about how to engage this from a more culturally sensitive point of view. So that's the sort of standard Western psychological knowledge, but it's also influenced very much by indigenous knowledge. And in that, I would talk about Holmes' peoplehood model, which underscores the relationality aspect in Indian communities, the relation to the land, the relation to ancestors, the relationship, of course, to creator, to children yet to be born, but the importance of feeling connected for psychological well-being. And then I also would say, after the fact, now social emotional learning is so popular that you can take this curriculum, and I know it sounds defensive, but I do see the core elements of social emotional learning throughout the curriculum: self-awareness, self-management, social awareness, relationship skills, and responsible decision-making. That's the theory. Next slide, please, Chris. So what I'm showing you here is the logic model for American Indian, or for, well, Zuni and American Indian life skills. And the reason I'm kind of tripping up on that is that after we had developed and evaluated this at Zuni, we were invited to the Cherokee Nation, to Sequoia High School, where there were 20 different tribes represented, to implement and evaluate the curriculum. And we modified it to use examples from a variety of different tribes, with the introduction in the beginning of the book to encourage people to adapt this to the beliefs of the tribe that they are working with. So then and with the permission of the leaders at Zuni, we were allowed to open up or sort of make a broader title to American Indian life skills. So anyway, this is just an example of a stress coping model that's used so much in the field. But I outlined a number of risk factors, and from a chapter I've written about this, but also from what the literature holds about risk factors for suicide among Native Americans. And I've divided it sort of into three categories, and that I think is helpful to think about: the ecological risk factors, what's always in the air, the ever-present, which it seems to be historical trauma and acculturation stress. And then, of course, in many areas, hard poverty. And then, of course, the social factors of community violence and family disruption, and then just interpersonal problems, and then the individual factors and of depression, substance abuse, psychological disorders, medical conditions that cause pain and that kind of thing, and gender orientation. And I realize that I mean, it sounds negative. We should have another column of protective factors, but I'm just trying to illustrate the stress coping model. So let's say someone has a few risks that they're going through. A stressful life event happens and people respond accordingly, fight or flight. Simply, in this case, I'm trying to emphasize that because in the work I've done, it seems to me that a common response is avoidant coping and, avoiding reminders of the past or defeat or humiliation or entrapment, using alcohol and drugs to self-medicate, or abandoning normal activities, so isolating oneself in their room or whatever, engaging in wishful thinking or keeping secrets, a kind of an avoidant coping pattern, which can lead to suicide because of ineffective problem solving or dealing with things. And we're trying to expand this to, can we have the next slide, Chris? To more of a cope approach coping approach. So we're doing the things that I was mentioning in a way about seeking knowledge of self, taking action, knowing how to monitor emotional arousal, discussing problems with others, seeking social support, etc. But I'm nervous when I talk about this because I realize that there are different approaches to coping, and some are more culturally congruent than others. I can say that in one of the studies I did a few years ago, when I used Folkman and Lazarus ways of coping and asked Native women at Harvard, Stanford, University of Nebraska, and University of Oklahoma to indicate when they had stressful events, what coping mechanisms they used, very much of it would be this more, removing oneself from the situation, going for drives, praying, listening to music. It was not so much this active coping approach coping. So I do want to at least acknowledge that I realize that. Okay, could I have the next slide, please? So this is the curriculum in essence. It's 44 lessons. It's divided into 7 sections. It brings a person into self-awareness in the first section. There are several lessons there. Then information about emotions and stress. Then into communication skills and problem solving. We added between the pilot and the final evaluation section 4, which is recognizing what it's self-destructive behavior, because we didn't want people to think into stereotypes about sort of a predisposition towards suicide. Why is it, do you think, that people might think this way? So we talk about, rights and we don't use the word colonization, but in essence, we're talking about that. We're talking about problems and why people sometimes do self-medicate, that kind of thing. What is self-destructive behavior, from not wearing seat belts or using a helmet, or, on and on, how it goes, it's progressive. But then 5 and 6 is sort of standard crisis suicide prevention. And then we didn't want to just get up to the, suicide prevention and leave people hanging. And so we added this final section, section 7, which is really individual and community goal setting, so that we look towards the future. So this is the curriculum. You might ask, well, that sounds so standard. It sounds like, conventional psychology. What's cultural about it? And in essence, it really is. I think there's a lot of deep culture in this, in that we didn't ask people specifics about their culture, but what we did is, in the process of developing it, we asked their input about their preferences. So for instance, when I mentioned the ways of coping, we met over the period of 3 years with every Kiva group in Zuni. And that was at the invitation of the person that had sponsored us to come in, who was the superintendent of schools. And his father was the governor of the Pueblo at the time. That was Mr. Lewis. And when we did this, for instance, we said, all right, we want to teach about coping skills. In the literature at this time, we have these 10 different ways of coping identified by Folkman and Lazarus. We didn't use those words, but basically we've got these 10 different ways of coping. We know that the youth will probably maybe remember 3. would you rank order these for us? What coping skills do you want us to advocate for? And I was rather surprised that their number one was problem solving. And then it went on to positive thinking, and then it went on to social support. So that's what we did, and that's how we built it in the curriculum, and in those kinds of ways. We have a lesson on grief, and in the lesson on grief, and which in all the years I've trained, it ends up being one of the most it's the most frequently nominated one that trainees will select when they know that they're going to, that they're being asked to demonstrate a lesson. And then in that way, people can talk about their traditions around and their protocols around appropriate grief. And so that's kind of the way it is. It's not all about, native art or place names or local idioms or those kinds of some more surface level things. I think it has some deep culture in there, but it's not anything that is inappropriate to share with the general population. You have the next slide, please. Okay, so along with all these lessons, we teach these basic skills: depression recognition and management, stress management, anger regulation, and then the suicide crisis intervention skills, which is sort of basic facts and myths about suicide, behavioral, verbal, warning signs, a 4-step plan for suicide prevention. They practice the suicide prevention with Confederate clients that we provide that are, if in fact the community does not believe in engaging in any role play around suicide, we provide the outside people, or we do it on the phone. We have these different ways of getting around that so that people can practice helping a suicidal friend or a suicidal family member get to help. So, and then we also have the goal setting section. Okay, next slide, please. So how effective is it? So I guess I'm learning a lot about culture as prevention, and there's an enormous amount of articles about this, and it's amazing to me to be out here and to see the very subtle ways that people are working in communities, really asserting culture as, in a way, and it being supported, by funding agencies, and it's amazing. I want to share just some outcome data. It's not all, because you see, at the time we didn't have this work on community-based participatory research. I mean, we did it, but we didn't have a label for it. And that's before, Nina did all her impressive work, and Bonnie Duran and all the people that write and do it just naturally now. But anyway, so how effective was this? This is the first time, the very first evaluation. And this is of the Zuni life skills in the high school. It was implemented in freshman classes and junior classes. We did, and with the idea with being in freshman classes is that we wanted to have it stabilized in the freshman year, so that all students going through Zuni High School would experience American Indian life skills, which went on for a number of years. It was offered 3 days a week, Tuesday, Wednesday, and Thursday. And in the evaluation, we had intervention classes and we had comparison classes. We wanted to randomize, but we were not allowed to randomize. We explained why we would randomize, because we wanted groups to be comparable in terms of, degree of severity or whatever. And so the administration chose which classes got the curriculum and which ones didn't. And after we did the pretest, we analyzed the data to see how the classes were distributed. And we found that those in our treatment group were a little bit more serious in terms of depression and ideation. And so in our final evaluation, what we did is we matched the treatment group with a comparison group based on their gender and their depression score. So we have a smaller number of students for the evaluation. We had 138 students participated in the evaluation, but in the published article, we are comparing the matched groups. So basically what we have is we have a significant difference in terms of treatment group in that those that received the curriculum were less hopeless. They were also more confident in their ability to manage anger. This was a self-efficacy scale around the skills of the curriculum. And surprisingly, managing anger, we only had 2 lessons on anger, but that was the one. And then we had a behavior, it was sort of a mixed methods in that we had the student survey, and then we also had the behavioral role play test. And with the behavioral role play, we ran at that by the time of post-test, we were able to randomize. And so we randomly selected out a subset, 30 students from the intervention classes and 30 from the comparison classes. And we put them through a behavioral role play of four role plays, 2 of helping a friend just solve problems, and 2 of helping a friend one who had insinuated that they were possibly suicidal, and the other that they had a direct plan of being suicidal. And again, in that case, we brought out college students who were young, and they were our Confederate clients. And then all this was videotaped, and we had trained raters and that kind of thing. So we had, good results in terms of behavioral role play, in that those that were in the curriculum were significantly better able to help their friends solve a problem, and also to do the 4-step plan for suicide prevention. How are we doing on time? I should be paying attention to that.
We have 24 minutes remaining.
Okay, very good. I can do this. Okay. So now the next, so that's one evaluation. This is an independent evaluation. I trained some people in New Mexico, again, different community, in American Indian life skills. And they told me, they said, we have the ability to go into the schools in the fall, but we only have 10 sessions, and you've got 44 lessons. What should we do? What lessons would you recommend? And I recommended 13, of which they chose their 10. And they implemented 10 AILS lessons in 5 different schools with 90 students. The students were, gives you a sense of their traditionality, in that 50% of the students used a language other than English in the home. Okay. And so they were able to look at, this is a pre-post, there's not a comparison group. Oh, it's the next slide, please, Chris, I'm sorry. Jump ahead, if you could, to the next one. Yes, okay, thank you. All right, so this is pre-post, no control group. And what we saw is this, and this was done by an outside group. They're program evaluators for a substance abuse prevention program that they had. They also evaluated these lessons. So we saw significant differences in hopelessness, suicidal risk, and significant increases in public collective esteem, which is a dimension of racial identity, where you are assessing how you think other people view your group. How do other people view my community? Also increases in self-efficacy and increases in self-awareness. Okay, thank you. Next slide. Okay, so given the staggering rates of suicide among younger Native students, we felt that we had to develop a middle school intervention. So we did. It's sort of based on the high school intervention, but it's more developmentally appropriate. It's a lot fewer words. And we piloted it with the Omaha Nation in Nebraska and Chief Leshai School in Tacoma, Washington. And we also got feedback from the Indian Country Child Trauma Center at Oklahoma State University with Dee Bigfoot's her program with interventionists that have worked in trauma. And so we reduced the dosage down to 35-minute sessions, and we included a student workbook. So we have this program, this middle school version now. Now that I'm here in New Mexico with some of the people I'm working with, we are modifying the scenarios to be more relevant to this period in time. adding more incident, or basically more information, for youth that go between urban and reservation areas back and forth, and some of the problems that are more, because this was developed in 2012. So you see, it's even aged in that. It's not in the public though, and I'll explain to you why with the next slide. Okay. Basically, we were invited back to Zuni 18 years later to do the evaluation with the middle school version, and Zuni was able to get a grant with the Margaret E. Casey Foundation for the grant. So it was a small grant, but it still helped us to be able to do this. We engaged 141 middle school students, and the middle school students were randomized into those that received the curriculum and those that did not. We were able to do that over the summer with the school counselor, so that the youth didn't feel randomized at all. They were randomized into their social studies classes. So classes received curriculum or didn't, but they had been randomized before school started. Okay. So we were able to give the curriculum over, it was the 35-minute sessions, and we had 6 weeks with which to do each group. So we had basically a treatment and then a delayed treatment. So we pre-tested everybody. Then the first group went. We post-tested the first group and pre-tested the second group on the very same day, very same time. And then we had the second group go for 6 weeks, and then we post-tested the second group. Okay. So the ideal would be that we would have differences between the first group's post-test and the second group's pre-test. And we did on efficacy items, but we didn't get them on depression or suicidal ideation or hopelessness like we had hoped. But what we show you here is the difference between the pre-test and post-test with the intervention group only, and in the self-efficacy items. So they increased in their ability as a result of this 6 weeks, and in their confidence in their ability to manage depression, cope with stress, enlist community support, and enlist social resources. So can I have the next slide, please? And then hopefully we'll get to Q&A pretty soon here. So the takeaways from this, I think, are that schools are often overlooked as sites for suicide prevention. There have been, in addition to American Indian life skills, there's also sources of strength. And I've had good experiences with CAST by Leona Eggert. CAST, which stands for Coping and Suicide Prevention Training. Anyway, and it's also been employed across a number of settings in urban areas, as well as charter schools, as well as BIE schools or tribal schools. Many Native youth have benefited from school-based suicide prevention interventions. We realize that we have not adequately covered the community or family, and that's because it's difficult to do. It's been very hard to bring in a family component with this. The way it's been engaged with community components is that we've had the experience of working with parent committees and Head Start programs that they've taken on the life skill. They've basically gone through the life skills, the high school version themselves, just for their own self-development. It's been used somewhat in Indian Boys and Girls Clubs. It's been used in tribal colleges and universities as a resilience course, where I've sort of given shared a resilience syllabus, and then they've used American Indian life skills as a case example of something that could be applied. And so that's kind of the array of different kinds of things. So I would say that we have still concentrated too much on the individual. We need to do more in terms of communities and families. One of the most promising, I think, venues for family work was done with Blackfeet community in terms of teacher home visits, like the Olds nurses' home visits in a way where teachers were able to do home visits with cooperating families on a regular basis. And as it turned out, there had been a cluster of suicides that were going on at the time, and that's mainly what the parents wanted to talk to teachers. So with that, I just want to thank you for your attention and listening to me, and I would love to entertain any questions that we have time for.
Is it okay to just jump in?
Of course, of course.
I'm thinking about the parenting intervention that we did. We didn't focus on the kids. We focused on the parents and the parents' trauma. And then they kind of blossomed. And so we're, that was in South Dakota, but we're working on a new project now that I think you're aware of, and Dee is, and Dr. Deidre, yellow, I want to say yellow hair, not yellow horse, but sort of related, but
we could almost be cousins, Maria.
Yes. So, I mean, so this is exciting because one of the things that we noticed was the parents were dying on the vine. So they just don't have the emotional strength because of their own trauma that's never been, addressed. And so in some of the parenting groups, it's kind of like, well, you have to do this and you have to do that. And they're just, it's hard for them because they're so bogged down with their own trauma. And like, how do I know how to raise my kid? They went to boarding school and it was abusive, and I went to boarding school. So I think there would be a really good, because we want to do more with that, we're sort of linking between parenting classes, parenting interventions, and then this with their youth, with the younger folks.
Well, you see, that's what I think is exciting in a way, even about that chart that had all these different interventions. I mean, parents need, so often we think of parenting with first-time parents or something. But you as a parent, those of us that have been parents know that you need help, you need support. You need some kind of, resources all along the way. And
even when they're older,
especially when they're older, just before they've, on their way. But adolescence is so hard. Oh, I hope I didn't. Am I still here? Let me see. Oh.
You're still here.
Oh, good. Thank goodness. I can't see the screen now. I don't know what I did, but anyway, I'll just talk. And I'll have to say that over the years of doing the trainings that I have done, which has been pretty extensive, I really love training on this curriculum. But it used to be so much about helping a suicidal friend. So I would say in the last 8 or so years, a lot of times we have youth talking about helping my uncle, helping my parents. In other words, that they use this, intervention, the 4-step plan, with their relatives for that very reason. It's just so hard, Okay, thank you. And the other thing I want to say about that, I'm just trying to get myself back here on the screen, is that, so often these interventions are in silos, and we really, it's important, for us to be able to blend them. And from a research perspective, that's hard to decide to do, but from the service delivery, it's very necessary. Am I still here?
Yes, you're still here.
Oh, this is amazing where I can't see the screen right now, but anyway, I'll just.
I can relate. I've had more trouble with Zoom today than in the past 6 months, it seems. And but I'm all good on screen, so I'm watching for any questions.
Okay.
Other questions for Teresa?
Yeah, this is James Fairfax Colombo. I'm an assistant professor in the department. I had a quick question about, and I feel like this is often what happens when you do this type of research, where it might be hard to measure the long-term behavioral impacts. But I always like the self-efficacy measures because there's any number of behavioral theories that would suggest that if there's self-efficacy in a thing, that you're going to see it translated out. But have you heard anything anecdotally from individuals who have gone through the curriculum in terms of like feeling like it really did have a really strong behavioral impact on their life, or anything like that? I would just love to hear some of the sort of the stakeholder accounts.
Yeah, definitely. For instance, in the problem solving section, we use Schinke's SOTA problem solving model. Okay, stop, options, decide, and take action. And it's so easy. It's so easy for youth to remember. Dr. Jody Rachel Green, who, by the way, taught after we were at Sequoia High School. She was a language arts teacher, and she was one of the ones in the evaluation. She persuaded the school to let her be the American Indian Life Skills curriculum teacher. So she taught like 5 classes a day for 5 or 6 years until some funding reason that they weren't able to do it. But anyway, she taught it at Sequoia High School for all that period of time. And she tells the story about seeing this one of her former students in the parking lot at Kmart, comes up to her, Miss Green, remember soda? Remember soda? No, I use it all the time. And I've heard that so much. I mean, that's the one that keeps coming back over and over again. I've heard, I don't know, I can't remember like all the details of the stories, but just to say that people really do tell me that they still use it. And it's been in existence for quite a while. I've trained people from over 100 reservations over the years. And so I feel like just the fact that it still exists and that is, we're working right now. We've adapted it for virtual training. I don't think it's as good as in-person training, but I guess it's just hard because I'm tired of Zooming. But we were asked to do trainings very regularly, and we really. So I would think that it's still working, or it wouldn't be in high demand. Mm-hmm.
Thank you for this presentation.
Oh, you're welcome. The thing is, I do also want to comment about the more distal measures. I was invited to present about this at Penn State by Mark Greenberg a few years ago, and I shared the results of the middle school version with them, kind of with my frustration about the fact that we didn't get the results I had hoped we would get, and that I'm leery about putting it into the public until we do another evaluation. And what they were saying is, you're really trying, you only had 6 weeks, you had 30 sessions with young children, and that's very hard to see a change in something like depression. And they were encouraging me to think about other measures such as belongingness, psychological well-being, grit. I'm having a little trouble with grit, but some of these other more positive psychology measures, as the more proximal measures, that we would probably get good results on that. And that's what my dream is. And actually, I'll have to say, my hope is that in order to do the study that I would like to do, I would need to do that in more than one reservation, either simultaneously or very near in time. And so that is what I'm hoping for. I've been able to get 2 reservations interested and 1 committed, and the second one was almost there. And then by the time I got the second reservation, the one that had been committed is not as interested anymore. And as you know, people are very interested in things that they think work, and feel kind of frustrated about having to do another evaluation when we think it already works. And so sometimes I wonder, well, should I just go ahead and publish this other one at the middle school level based on the success of the first, of the high school version? I'm really not sure. So if anyone would like, you see my email, and if anybody's looking for, an intervention study they'd like to work with, I certainly have it all designed. Curriculum's ready. We're refining it to update it now, and I'm really ready to try to get the money to have it happen, and love some consultants or collaborators to join me. Maria. Yeah. Thank you.
Yeah, and I was thinking that, yeah, there might be thing where we could have the parenting thing going on at the same time, because,
I think that'd be a great idea.
yeah, that would really be
Mhm.
getting harder now.
The parenting group and a randomization where families get parenting and the middle school curriculum. And then maybe some who just get the middle school and some who just get parenting.
Exactly. Exactly. You know, one of my doctoral students, we just had a proposal meeting yesterday, and she's working with children from war-torn countries and working with to understand from a parent's perspective what are the social emotional competencies that they want their children to have, because they're in a very, very different situation. And looking at all the social emotional, learning curricula, it's that do exist. A lot of it emphasizes, empathy and, self-monitoring and those kinds of things. And so anyway, she has done a very interesting process of developing the curricula along with parents to understand what it is that they really feel that their children need. And in the case of like managing conflict, what most parents, the SEL curricula would say, to show empathy and to try to take the perspective of the other person and try to, agree to disagree or, politely get along and those kinds of things. And with the parents in these situations, they think that they would recommend that their children just walk away. Even if the child is getting hurt, they just walk away, stay away from conflict and those kind of things. And I think I think that there's really some interesting work that we could do by trying to work with parents to understand, in a way, how they, that this idea about what is the appropriate way of coping in this situation and this point in time, sort of like almost like precision mental health related around this.
That's really interesting, Dr. LaFromboise. I think I mentioned that Dr. Simmons and I have been working on just emotional identification with the middle school group and the community we work with. And it's been really interesting that we get kids from the 6th grade level who don't know quite yet how to identify the emotions they're feeling, but they're feeling them on such an intense level that they don't know what to do with it. So it turns into tantrums in the classroom, tantrums at home, or what we would perceive as tantrums, but it's just this bottled up, intense emotion. So we're trying to teach identification and regulation in these classrooms. And this is only the second school year we've done it. And I think the next step would be to start some measuring from beginning of the school year to end of school year after these in-classroom interventions. I really appreciated the prevention slide that you had at where, prevention is helpful, because it is really helpful on all spectrums.
Thank you. Oh, it's good to see you again. Thank you very much. Yeah, and I think there's so much that we could do. I mean, to me, you could do it here. I mean, because there's so much creativity going on in the field of prevention and mental health and culture. And Key, I see that you're here in the group. You've got your hand up. I mean, I can't believe that I went to your presentation this morning, and it was just amazing in terms of, what people are doing, for suicide prevention around, digital stories and art. And if you could just think of all the, the possibilities. And the thing is that can happen I want to go back to the point about schools. I also feel like it's very timely right now, because those people who are in school settings realize how difficult it is for youth right now, returning to in-person schooling after being out for such a long time and going through what we've been going through. So Dee, did you have a question? I mean, Key, I'm sorry.
Yes, I do.
Okay.
First, thank you so much for this presentation. I'm here with Lucia Jose, who's a native evaluator, and we've been having some really awesome conversations too around this. What caught my ear was the pieces around family intervention and how American Indian life skills, I could just see a huge benefit in bringing that more out to families, because I know during the pandemic, especially, the Native communities that we were working with here in the area, it was one of the biggest overwhelming responses we got was from families who now spent so much more time with their students, who had so much more increases of mental health issues and concerns that Native families just felt like they did not know how to deal with at all. And so I really saw how much they wanted to figure out, like, how do they help their children? How do they know what's going on? And so another thought that I had too is because so many of our Native communities have been in such unique situations about how much more time that they've been sort of in this isolation or in this online schooling kind of mode. But one of the more effective things of the pandemic has been able to reach out to more family through online venues. And so really thinking about, like, even doing that kind of adaptation for the family component, regardless of whether we do Zoom or not, but just because it seems like in some ways it's been a more effective way to do outreach to families and to get them participating in trainings and community collaborations and gatherings like this.
Mm-hmm. So you see, I mean, it would be wonderful to be able to be implementing this and then having ongoing, at least weekly meetings with families so that they understand what the kids are learning and that they do some of it themselves. And then that way they, know what's going on, with them, and, if they like it, they would reinforce it. But I was involved in a project a few years ago that was amazing. It was funded by NIAAA, and this was sort of a cultural adaptation of the Strengthening Families program, and Les Whitback was the PI. And what they did is that they modified a curriculum, some of ALES, for youth around substance abuse prevention. And they had weekly meetings. It was a community-based intervention. So each child brought an adult with them. So they had a mentor or a caretaker that came. As long as they were adult, fine, from the family. They had their orientation about what the youth were learning, and the youth had their training. And then, of course, then they had a meal. And it was quite effective. I mean, that's a great model. That would be wonderful to be able to be doing that kind of thing. And then, of course, they had every family that did so many lessons, they got, a winter coat, and then they had a raffle for a snowmobile. I mean, there were nice perks, but still, it would be great to be doing something like that. And actually, when you think about it, we ought to be able to do things like that with as a way of reparations for what's been going on and what we're all aware of should happen in terms of some kind of reparations for the boarding school disaster.
Well, I'm aware of the time, and I appreciate everybody hanging on who can. I know some have already had to leave to get to clinics and so forth, but it's such a rich discussion. Teresa, thank you so much for being here. And it seems like there is a lot of opportunity for collaboration, a lot of need here in our communities, and a lot of opportunity to try to push forward with some of the research that you've been talking about. So thank you so very much. I think we need to put up the QR code again for people's continuing education and registration. But if you didn't get Dr. LaFromboise's contact info and you need it, I think the presentation will be up on the departmental website, so you could easily go just get that PowerPoint. Her info is there, or reach out to me directly, and I'll hope for some future collaboration.
Wonderful. Well, thank you very much, Chris, and thank you everyone for coming and spending time.
A real pleasure. Goodbye, everyone. Have a great afternoon.